everybody. So I'm Mason and this is Kiki, and today we're going to tell you all about ACL repair surgery. So some objectives that we want to cover today during this presentation is to define what an ACL repair is, discuss the indications for the ACL repair, discuss the precautions before and after surgery, as well as the contraindications before and after surgery, discuss the method of the procedure, and discuss the rehabilitation process during the maximum, moderate, and minimum phase of rehab. So a little bit about the ACL repair surgery. It is the most common sports injury that is in the knee, and it typically occurs like during football when a player is cutting or running on like turf and things like that. And this is obviously just a repair of the anterior cruciate ligament. And it's also commonly associated with MCL tears, as well as the medial meniscus, and this is known as the unhappy triad. And for the surgery, it is replaced with a graft. It's either with an allograft or a autograft, and the autograft is used from like your own body, and it's from the hamstring group, the patellar tendon, or the quadriceps tendon. And for the most common ones, according to our therapeutic exercise book, is the hamstring and the patellar tendon are the most used, and the quadriceps is rarely used. So a little bit about the indications for the surgery. Instability of the knee would be a major reason for having the surgery, and like just frequent periods of like your knee giving out, like just walking in Walmart or something you say, and you just feel like your knee is going to go out any second. Positive pivot shift test, which is a very high specificity for the anterior cruciate ligament, injury to the MCL along with the ACL, and a re-injury risk to due to active lifestyle for like athletes. So like many normal like everyday average Joes, they don't really need this surgery specifically unless they have like kind of periods of like just knee giving out constantly, and they can perform ADLs and everything like that. But for athletes, they are very recommended to get this surgery because, I mean, I'm sure we've had some people in here play with the torn ACL, and it's pretty hard.
For some precautions, there really weren't any that were just super specific to ACL. Most of them, like your general surgery precautions, you should stop smoking, your alcohol intake, and certain medications and supplements. Post-op, you do have the risk of graft failure, especially with the allograft not being from the body. Your brain should be locked in extension when sleeping or ambulating, and there's not guaranteed 100% pre-injury activity levels, so it's not guaranteed that you're going to get back to the level that you were before your injury. So contraindications pre-op is anybody that's sedentary, they don't live an active lifestyle, they're unable to make the lifestyle changes that eliminates the risk, their inability to cope with episodes of instability, advanced arthritis of the knee, the poor likelihood of them complying with their post-op instructions or going along with their rehab program. Post-op, it would be you shouldn't do any resisted hamstring exercises for 12 weeks, especially if you use the graft from the hamstring. And you should not have any weight-bearing knee flexion greater than 45 degrees in the maximum protection phase. So for the procedure, of course, your patient will be placed under general anesthesia. Surgeon will make a small incision. They use the arthroscope to visualize the inside of the joint. They use the instruments to remove the ACL. And then it's really the type of graft that you get really depends on surgeon preference. You have different things like age, gender, lifestyle. As Mason said earlier, you can use the autograft or allograft. Allograft comes from the donor. The autograft comes from part of your body. The gold standard used to be the patellar tendon, but the hamstring tendon is becoming more popular nowadays. It's more
here's typically kind of what like a rehabilitation process would look like for an individual with the ACL repair. I mean, as we know, there are several protocols out there, and I kind of got this from what others seem to be like kind of a gold standard, and from our therapeutic exercise book. So during the maximum phase of rehab, some of the goals that are included that are protecting the healing tissue, and we want to have a range of motion from around 0 to 110. And the reasoning for this is not stretch that graft that we just placed into the body. We would want to have active control of the range of motion. And this is kind of like our weight bearing test. So post-op, immediately post-op, we're around 75%. And we kind of progress as the weeks go to a weight bearing is tolerated. And then hopefully by the end of the maximum phase, we are full weight bearing as tolerated, or full weight bearing. Some interventions that you'll see during this time are the price method, fast range of motion, active range of motion, patellar mobilizations, as Jada mentioned, kind of with the TKA. We also want to do this for the ACL. Muscle setting isometrics for the quads, hamstrings, and then gait training and NMES. And so some therapeutic exercises that you'll kind of see during this phase are prone hangs, heel slides, the straight leg raise with the four-way, so working on your hip abduction, all the extension and flexion, and then we'll also do quad sets and TKEs. And so during the moderate phase, some of our goals are full pain-free range of motion. We want to have at least a 4 out of 5 manual muscle test strength, dynamic control of the knee, and we want to kind of begin to normalize our gait. Some interventions during this is that closed chain strengthening, proprioceptive training, stabilization training, active range of motion, and MES. We'll also see kind of like half squats, step ups, single leg balance, bridges, lateral step overs, like onto like a riser. And then this is kind of where we'll begin like our walking or jogging program. And during the minimum phase, our goal is kind of regain the function to a level as before. As Kiki said earlier, like you're not guaranteed to be 100%, but like for an athlete, in our case, we want to get them back to better than they were before. And if you're, somebody just loves to like just walk around the neighborhood thing, we want you to still be able to do that. So we're trying to regain that level of independence back. We're also obviously going to increase the strength, endurance, and power, and safely initiate the sport-specific training program if they were an athlete. So during our interventions, this is kind of where we begin our plyometric training. We kind of simulate what they'll be doing like in their work or sport environment. We'll also work on their endurance training and maintain their closed chain connect strength. So we'll do squats, leg press. We'll kind of work on more gait drills such as like karaoke, figure 8, back pedals, and we'll also do some lunges during this time.
So for a short overview, this surgery is a repair to the ACL. You do not have to have the surgery, because certain treatment can work if you catch it early enough, and also depends on the grade of tear that you have. Typically use autografts from the hamstrings and patella, and the rehab process lasts from about 6 to 9 months, with athletes having a longer rehab than people that just in a regular day life. These are our references.
Any questions? Go ahead.
Why is it important to know what type of graft your patient has?
For like when we're doing like mobilizations, exercises, and things like that, you don't want to stretch that graft out and cause harm to it and lengthen it out. It may just ruin like the surgery, and they may have to go in again and have the same surgery again.
And as I was reading up on, why they use the hamstring more now than the patella, they found that a lot of people have more trouble with knee extension, get back to full knee extension when they use the patella graft due to things like the stretching and stuff like that.
So, did y'all read anything about muscle activity and range of motion putting one at risk for ACL tear? For example, proximally, there's a muscle that if it's weak, it can increase the risk of ACL tear. Distally, if there's a range of motion at the ankle decrease, it can increase the incidence of an ACL tear. Did y'all read anything about that?
I read something about the vastus medialis being a big muscle for like controlling the knee. So I assume just relating, like extrapolating that the vastus medialis would be one of the key muscle groups of quadriceps for ACL repair if it's significantly injured.
Okay, what would the vastus medialis do?
Control the knee joint.
Is that going to be more related to the patella versus the ACL?
It can influence the knee joint as well. So, just thinking that there's a muscle imbalance, just you have to know what the vastus medialis is going to do or how it's going to act at the knee joint. So you got your vastus medialis, vastus intermedius, vastus lateralis, rectus femoris. So you got to know the muscle force. So when those muscles contract concentrically, what is the direction of those muscle forces? So I'm just trying to get you to think about how would the vastus medialis, what role would it play in the function of the knee joint?
Are you asking specific to your question, or is you saying
In general, what does the vastus medialis do? So you said it does knee extension. So what role would it play? So it play knee extension, so what would it do? What role would it play with patellofemoral joint?
Are you speaking about like teletrainers?
Yeah, patellotractor. Okay.
So maybe that goes back to the state of the MCL, the ACL, whole training.
Okay, so typically what happens, so say there's a muscle imbalance, I'm just talking about the vastus medialis right now. So if the vastus medialis is, say that it's strong, alright? So say that it's strong, it's taut, it's concentrically shortened, then what could happen is the patella could track medially, right? But then what would be going on at the tibial femoral joint? Were you going to get a varus or a valgus? This is what you have to know as well.
I say valgus because it's pulling your patella in and it creates that valgum.
Okay, so you said pulling your patella in, what is it doing to the tibia?
Sorry.
so the tibia's gonna go out as it's being pushed.
Okay, so you saying that it's moving the tibia more so medial?
No, I was saying the tibia's going
Lateral.
lateral, yes.
So you saying it's gonna create a varus? What do you say? You can present it.
I would think it would be valid, but that's just me thinking. If I'm going, I just think about my body and now I'm not me, remember that. So I'm thinking more valid. It's gonna be it's gonna come here. That's just my train of thought.
Okay, let's move proximal. We're gonna table that. So let's move proximal at the glute max. The glute max, right? What role does it play in controlling the knee?
Stabilization.
Stabilization of the knee. Anybody remember that from intro to ortho? The role that the gluteus maximus plays at the knee?
Prevents internal rotation.
Presents excessive internal rotation.
Prevents it.
Okay, so we're on to something. Somebody's got some recall going on. So it prevents excessive internal rotation of the femur on the tibia, right? All right, how is that?
Produce the valgus force at the knee.
So Andrew said it is a powerful external rotator. Therefore, it has to be strong how to prevent excessive internal rotation of the knee. It has to be strong eccentrically. So the gluteus maximus muscle is a muscle that plays a major role on how the knee functions during gait or even during running. So it predisposes someone for being at risk for ACL tear if it is weak eccentrically. Because when a person is running or walking, if it is weak eccentrically, you're gonna get excessive internal rotation of the femur. As a result, what else do you get in conjunction with that excessive internal rotation? What might you see at the knee joint? Starts with a V. Genu valgus. And now that's gonna put extra stress and strain, predisposing for an ACL tear. So make sure you remember that. Make sure you know that. That's gonna come back at you. I'll make sure I put that on the test. But it's from the literature as well. Now, also from the literature, I'm tying this in with your ACL because you're gonna come back and you can see this. You can likely see this on a National Physical Therapy exam because this is in your books. This is in your books. Now, at the ankle, which range of motion that if it is limited, it predisposes one for being at risk for ACL tear? Y'all may wanna write this down, because this is throughout the literature as well. Dorsiflexion. Good job. So according to the literature, if one has decreased ankle dorsiflexion, talocrural dorsiflexion, it predisposes someone for being at risk for ACL tear. That Prentice, William E. Prentice, has a lot of literature on that in his sports medicine that I don't know what book y'all using, not gonna use in sports physical therapy, but likely it's gonna be in whatever textbook that you all use in sports physical therapy as well. But it is in Cosner and Colby. And I think it may be likely in Dutton as well, but I know it's in Cosner and Colby. Now going back to the vastus medialis. So the vastus medialis, right? It helps with controlling tracking of the patella, lateral tracking of the patella, right? So it's gonna keep it neutral. It helps with stabilization of the knee joint. But what if it is overactive? That's what we wanna know. What's gonna happen if that vastus medialis is overactive? Is it gonna produce a valgus or a varus?
I would say values, so I'm going to anti-rotation.
Yes. So if it's overactive, if it's overactive, if the valgus medialis is overactive, then you could likely, that could also predispose for ACL injury as well, because it's gonna result in tibia internal rotation, which can result in a valgus as well. Okay, so you gotta know how those muscles at the knee joint are gonna act, alright? If the vastus lateralis is overactive, what is it gonna do? It's gonna pull the tibia into external rotation if it's overactive. Alright. Dr. McCurry.
I have a question as well. So on your rehab slide, protocol slide, if we go to and look at the max protection phase. So I noticed too you had in the Therex TKE. Right, so what's that stand for? Okay, terminal knee extension, right? So I guess my question would be, would you think that you would do that in an open chain manner or a
No.
closed chain manner in that maximum rate?
You're supposed to avoid open chain. Sorry, I forgot to mention that during as well. But during the maximum monitors, you're supposed to. That's one thing you avoid is open chain knee extension, because it stresses that graft that we just placed in the body. And it says in the Therex book that one thing you should not do, and most therapists mess up, is go from sitting at a 90 position, so short sitting, and going to 0.
Good. But sometimes in that maximum protection phase, could you do it standing? So you could start to initiate a little bit of that range in a closed chain position, but you do want to avoid open chain. So good job.
I want to point out something else that y'all can potentially see on National Physical Therapy exam as well. Most injuries at the knee occur when one is moving in the frontal plane. So what does that mean? Lateral movements, okay? So you gotta train lateral movements. You gotta make sure you incorporate lateral movements within your rehab protocol. So I see you have lateral step overs, that's good. You have karaoke, that's good. And so you got lunges, so you wanna make sure you do lateral lunges, that's good. So you gotta train in the frontal plane. We often train in the sagittal plane, and we stick to the sagittal plane. And training, most of our training is in sagittal plane, but we gotta remember, we gotta train in the frontal plane, hip abduction, hip adduction, cause this is where your injuries are gonna occur mostly. And that's across the board in the literature. That's across the board in the literature. So make sure you remember that.
Okay, one more question too. So I've heard, and this is for several of you, I've heard rice a lot, and I can't remember, have we talked about, or have you guys talked about in your class, police versus rice method? You guys all understand what the police method is versus rice method? So remember that, protection and optimal loading, right? Optimal loading is important, and you may have even seen some reference to that on your quiz today. So remember that. So, and that's where the, right, optimal loading. So you're optimally loading the graft and the healing tissue in your max protection phase.